Good morning and welcome to Tandem HR's webinar, Affordable Care Act Made Simple. My name is Rebecca Buckland. I'm a senior HR consultant here at Tandem HR and will be presenting today's webinar. With me this morning is Courtney Vandermeulen, Assistant Director of Benefit Solutions Group. Our goal here at Tandem HR is to simplify the people processes, enabling organizational leaders to maximize return on investment in people and concentrate their efforts on driving organizational success. As HR experts, we aim our webinars to provide a value add for our clients, owners, and their employees. To omit any static or interruptions, I have placed everyone on mute. If you have any questions throughout the presentation, please feel free to type them into the question box on the right side of your screen. If you have individual or personal questions, please feel free to contact me or your HR consultant offline. We will be addressing your questions at the end of today's session. As a special note, we will be live on Tandem HR's social media sites, including the Twitter chat. You can use hashtag TandemACA on Twitter during the webinar to connect with us live. So let's get started. I would like to first take a poll to get an understanding of what reform you feel will benefit you, the employer, the most. So our first poll question is, which impacts you the most? A, ACA, B, Obamacare, C, Affordable Care Act, D, Patient Protection Act. It appears that, by the answers received that we will be most impacted by the Affordable Care Act. There have been several polls from comedians to entertainment broadcasts to mainstream news reports asking the public the same question under each name. In all cases, the polls found that more Americans oppose Obamacare than oppose the Affordable Care Act. Confused? I understand, since the truth is all the names shown represent the same law. We share this with you because you are not alone when it comes to the Affordable Care Act confusion. The Affordable Care Act, ACA, has attracted critics, supporters, and media bites for the past several years. Everyone, including the federal government, state governments, health insurance carriers, employers, and individuals are affected by ACA. Consumers worry about having access to good doctors and hospitals at reasonable prices, while employers are concerned with the complexities and costs of complying with ACA. We are here to help you understand the key components of the Act. Let's take a look at what we will be speaking specifically about in today's webinar. During the next hour, we will help you navigate the ACA and this handy chart. Well, okay, handy may not be the best descriptor, but our commitment is to make the ACA as understandable and as simple as possible. Therefore, we will be reviewing a brief history of healthcare reform, what led us to reform, the ACA's past, present, and future, key aspects of the Affordable Care Act, what you need to know, how this will impact your business, and what next steps you, the employer, need to take. There is a wealth of information and opinions from many multiple sources available to us every day. We have used many of these sources to aid in the information presented today. Our goal is to put you at ease with a better understanding of the ACA and serve as a resource to you when you are ready to dig deeper or need additional assistance. The first attempts at healthcare reform occurred between 1912 and 1935, when President Theodore Roosevelt ran for president on a platform that included healthcare reform. He stated that he supported, quote, the union of all existing agencies of the federal government dealing with public health into a single national health service without discrimination against or for any one set of therapeutic methods, school of medicine, or school of healing, unquote. Once in office, and with the Great Depression impacting Americans, President Roosevelt was forced to remove the publicly funded health care reform from the Social Security legislation. More than 50 years of debate and failing under the Social Security 20 years before, President Lyndon Johnson signs Medicare and Medicaid legislation into law. He used these endearing comments, quote, "We marvel not simply at the passage of this bill, but it took so many years to pass it," unquote. At the cornerstone of the Clinton administration election agenda was the reform officially known as the Health Security Act. The core element of this health care reform package was a forced mandate for employers to provide health insurance coverage to all of their employees through competitive health maintenance organizations. The administration was unable to sell it to the people, pharmaceutical, and health insurance industries. Therefore, it was declared dead. Now, most recently, and with the strong support of President Barack Obama, the Patient Protection and Affordable Care Act was signed into law on March 23, 2010. With the purpose of improving the availability, quality, and affordability of health insurance in the United States. With all this history, there are three main components that have really brought about and are now being addressed within healthcare reform. They are the rising cost of healthcare, the gaps or holes in insurance coverage, the uninsured or underinsured. The Congressional Budget Office reported that there were 53 million uninsured persons in the United States. The Affordable Care Act was established in part to address these specific 3 points. The Affordable Care Act has certainly been a phased-in approach. Let's take a look at what occurred between 2010 and 2014. There are 5 areas to speak to. Adult child coverage until the age of 26. This reform stated that a child, son, daughter, stepson, stepdaughter, and eligible foster child would be permitted to be covered as a dependent up to the age of 26, as long as they were not eligible under their own employer plan. The Kaiser Family Foundation estimates that 600,000 young adults were added to coverage in 2012 because of this reform. Within this time frame, the ACA mandated that there would be no pre-existing exclusions for children under the age of 19. In Illinois alone, there are as many as 750,000 children with pre-existing conditions. A bit over 3,000 children in Illinois with pre-existing conditions have gained coverage since this program began. The ACA also governed the lifetime dollar limits on essential benefits. This eliminated the worry of chronically ill persons who may have come close to or reached their insurance company's lifetime limits for coverage. At this point, there are no lifetime limits. In addition to the lifetime dollar limits, the reform restricted the annual dollar limits on essential benefits, allowing for no limits on annual coverage. HSA, HRA, and FSA limitations were included in the reform during this time frame. There is a limitation on over-the-counter medications to be covered under these benefit plans. Only prescribed drugs and medicines, including insulin, and medical devices and supplies are considered qualifying medical expenses and subject to the preferred tax treatment. But wait, there is more. In 2010 and 2012, preventative services were now covered with no cost sharing, meaning that preventative health services would be free from deductibles and copays. Services included, but are not limited to, colonoscopy screening, pap smears and mammograms for women, well child visits, and flu shots for all children and adults. The Women's Preventative Services portion required insurance coverage to provide women's preventative coverage at 100%, meaning no copays, deductibles, or coinsurance by in-network providers. Services included for this annual well woman visits, screening for gestational diabetes, testing for the HPV, contraceptive methods and counseling, among many other services. Small business tax credits were introduced, aiding the long-paid premium pricing for health insurance. The tax credit was made available to businesses that had no more than 25 full-time employees and that paid up to an average of $50,000 annual wages and provided at least half of the single coverage premiums to the employee. A point to know that is a company can go back and file amended returns to receive the credit for 2010 through 2013 as eligible. We would recommend that you consult with your tax accountant directly with questions related to this credit. Finally, the medical loss ratio was established. This was to ensure that insurance premium dollars were spent primarily on health care. The law requires that at least 85% of all premium dollars collected by insurance companies for large employer plans and 80% for individuals and small group employers are spent on health care services and health care quality improvement. If insurance companies do not meet these goals because their administrative costs or profits are too high, they must provide rebates to consumers. Let's now take a look at 1 year later, 2013. Last year, 4 components were introduced: W-2 reporting, summary of benefits and coverage, FSA cap, and written exchange notices. W-2s distributed to employees of large employers starting in January 13 and annually thereafter required the reporting of employers' aggregate cost of coverage for employee-paid benefits. As a special note, W-2 reporting remains optional for small employers, which are employers filing fewer than 250 W-2s. New rules regarding the summary of benefits and coverage, SBC, and uniform glossary became required. This mandate required that all new hires and re-enrollees must receive a uniform explanation of coverage and standardized definitions that actually describe the benefits and coverage under the plan. To be very clear, the expectations were set very specifically. For example, the SBC must not exceed 4 double-side pages, contain words that are and culturally appropriate, detail premiums and coverage features, patient cost sharing for each essential benefits category, rules regarding the use of network providers, and whether the plan meets the standards for minimum coverage. This is the first potential penalty that we will discuss. If the employer is not in compliance, the penalty for not following this act is $1,000 for each failure to provide an SBC to an individual and $100 per day per affected participant. The good news is that there will be no penalties during the first year on plans or employers that are working diligently and in good faith. Also in 2013, the flexible spending account benefit cap was reduced to $2,500. Finally, by October 1st, 2013, every business with at least one employee and $500,000 in yearly revenue must provide all employees a written exchange notice, informing them that the healthcare exchanges were open, that the employee may be able to get insurance on the exchange, even if they have coverage through work, and they may be eligible for potential premium credits. Well, we have now made it to present day. 2014 is proving to be a busy year for the Affordable Care Act. There are 9 new provisions introduced. We will review each of them for you. Individual mandates were made individual persons responsible to purchase insurance coverage or face tax penalties. All U.S. citizens and legal residents must have minimum essential coverage starting January 1st. If a person decides to not purchase insurance coverage, they will incur what is being called a conditional tax. The conditional tax amount will increase during 2014 to 2016 from 1% to 2.5% of household income, or $95 to $695, whichever amount is greater. Adjusted community rating for small employers became effective also on January 1st. The included items such as no medical writing, no pre-existing condition limitations, guaranteed renewability of coverage, and no gender differentiation. Prior to the ACA, health insurance companies used extensive formulas to forecast the likelihood for illness based on age, gender, and medical history to assign risk for cost exposure. Community ratings limit costs for the highest risk group to no more than 3 times the lowest group. This is beneficial for companies with a history of large health claims that may have driven up past premiums. Community rating may fall harder on younger, healthier organizations. As of January 2014, all small employers in a particular geographic region must get the same premium rate, although adjustments are permitted for age, tobacco use, and family size of group members. Guaranteed issue. The guaranteed issue component states that coverage must be guaranteed for all individuals in fully insured small group health plans. Pre-existing conditions clause mandated that insurers will not be able to exclude individuals or employees based on their pre-existing conditions. Moving on, waiting periods. Waiting periods for coverage cannot exceed 90 days from an employee's date of hire. Employers' waiting periods are being adjusted by carriers at their next renewal date. Annual limits on essential health benefits are prohibited. New ACA taxes and fees will impact premiums and rates. These taxes and fees include the patient-centered outcomes research fee, which is a $2 per member per year and is subject to increase. Also, the insurer tax, which is approximately 3.5% of the premium to fund health exchanges. The Transitional Reinsurance Act, which is effective for 3 years as exchanges develop and mature. I know I went through that a little quickly, but we will review these with a bit more detail a little later. Small group cost-sharing limits are linked to HSA limits now. Exchanges, or health insurance marketplaces, opened in 2014. As a side note, government subsidies are only available when utilizing the state or federal exchanges. So finally, this brings us to current states. Let's take a glimpse at what is to come next year in 2015. In 2015, we, the employer, need to consider the following. Will you play or pay? As an employer, you will need to evaluate if you are better situated to pay the fees for not complying or to follow the ACA guidelines. A couple areas to consider are affordability and minimum actuarial value. A note on this, during the creation of this webinar, another change to the ACA mandate occurred. On this past Monday, February 10th, we were informed that the play or pay penalties under the employer mandate have been delayed for employers with 51 to 99 employees for another year. This is just another example of how the ACA is always changing. As it relates to affordability, is the company's health coverage affordable, and does it provide minimum value? Answering no could cause the employer to be subject to fees and penalties for each employee. Coverage is affordable if employee contribution for single coverage for lowest cost option that provides minimum value does not exceed a calculation determined by the ACA relevant to the employee's pay and poverty level. The employer plan is required to meet the minimum value of coverage, which is at least 60% of the minimum actuarial value. There are minimum value calculators, safe harbor checklists, which are pending, and certifications by actuarials that can be used to determine if the plan meets this requirement. Documenting benefit offerings. You will need to consider if you have systems in place that will prove that you have offered employees and their dependents health insurance coverage. As a note, it is the offer of coverage, not the acceptance of coverage, that is key to avoiding a penalty. It is imperative that employers carefully document all responses from employees. Tracking procedures. Does your organization have procedures in place to track the names, addresses, social security numbers, and dates of coverage for all employees and dependents enrolled in its health insurance plan? Employers will be required to file new information returns with the government to report this information for 2015. Now is the time to start planning for next year. The good news is that you have time and resources by your side. Wow, we just reviewed years of information, and it is clear that there are a lot of expectations. So let's take a momentary breather. Looking at our second poll question of the morning, how would you answer the following? Are you, the employer, and your leadership team planning to A, keep employer coverage, B, pay the penalties, C, really unsure what to do? Take a few moments to select your answer. Wow, pretty obvious from the responses. Our audience today appears to be planning to keep employer coverage. We are seeing that many reports are indicating that most employers plan to continue their full-time health care benefits for at least the next 12 months. So our poll question was right in line with our research and the reports that we're seeing, at least for the next 12 months. However, many employers indicate directing their part-time employees to an individual plan option or the exchange. Longer term, employers are taking a wait-and-see approach. Remembering our focus is to make the ACA simple for you, let's move along to the key aspects and fees associated with the Affordable Care Act. When reviewing the complexities of the Affordable Care Act, there are some key aspects that you must know. The first concept is, are you a large or small employer? The answer to this question will drive what mandates and timing you are required to follow. Large employers are defined by the ACA as an employer who employs 50 or more full-time employees. Currently, small employers are defined as having at least one, but less than 50 full-time employees. Effective in 2016, small employers are going to be defined as organizations that employ up to 100 employees. Finally, within the definition of large and small employers, the ACA references full-time equivalent employees. These are employees working 30 hours per week on average. This is one of the most concerning topics for organizations. How are they going to track and calculate the number of full-time equivalent employees they have? Furthermore, under the ACA, hours worked by part-timers are totaled to determine the number of full-time equivalent workers an organization has. As a result, business owners are whether they will exceed the threshold that would require the company to offer health benefits in 2015. For example, if you have 30 full-time employees plus 60 employees that average 15 hours per week, you will have 60 full-time equivalents and could face penalties if you do not offer health coverage in 2015. I'm going to take you through that equation again. You have 30 full-time employees plus 60 employees that average 15 hours per week. You will have 60 full-time equivalents. And again, could face penalties if you do not offer health coverage. Let's take a closer look at the full-time equivalent concept. When we assess how many full-time equivalent or part-time employees an organization has, we have 3 periods of time that need to be assessed. Most importantly, any employee on your payroll for an average of 30 hours per week or more during the defined period should be considered a full-time employee as it relates to medical insurance coverage. All right, so looking at the measurement period. The measurement or look-back period is the length of time an employer must evaluate the hours worked by a variable hour employee to determine whether they are eligible for health care coverage in the upcoming coverage year. Currently, measurement periods must not be less than 6 months and needs to coincide with the stability period. The stability period is the time during the coverage year that a variable hour employee must be guaranteed access to coverage even if the employee is no longer working full-time, as long as they remain active with the employer. For the 2014 coverage year, eligible employees must be offered coverage for either 6, 9, or 12 months. The stability period may not be less than the 2013 measurement period. The final period for consideration is the administrative period. The administrative period is available to accommodate employers that might need some time between the standard measurement period and the standard stability period in order to determine which employees are eligible for coverage and for other administrative purposes. To prevent the administrative period from creating a potential gap in coverage, it must overlap with the prior stability period so that ongoing full-time employees will continue to be offered coverage during the administrative period. This part is very complex and can be very confusing, so I will try to summarize it for you. You have the administrative period to do the administrative aspects needed to determine who is eligible. The measurement period to confirm employee eligibility, and the stability period to offer coverage. I'm going to say that again. You have the administrative period to do the administrative aspects needed to determine who is eligible. The measurement period to confirm employee eligibility, and the stability period to offer coverage. All right, taking a look at affordable care mandates, there are two that we will speak of this morning: the individual mandate and the employer mandate. The individual mandate states that individuals will be responsible to either enroll in their employer's plan, purchase coverage, or face tax penalties. Individuals who choose not to enroll into medical benefit coverage will be required to pay a tax. The tax, which was discussed earlier, will increase from 1% of household income in 2014 to 2.5% of household income in 2016, or $95 in 2014 to $695 in 2016. Whichever of these amounts is greater to the employee. This tax is assessed per person not enrolled in medical insurance coverage. The information provided today is what has been released thus far and is subject for review and change after 2016. Employers will need to consider if they will follow the employer mandates governed by the ACA. This concept is also referred commonly to play or pay. The ACA requires companies to provide health insurance to their employees that is affordable and meets the minimum standards set by the Affordable Care Act, or incur penalties for not complying. Companies are now evaluating if it is the best interest of the organization to either offer the benefits or pay the penalties. One item to consider is the tax savings that companies receive by contributing to employer-provided coverage. Now, I know that Courtney has discussed this with many employers and has great information that she can share. So, Courtney, what are your thoughts on play or pay?
Thank you, Rebecca. I have had numerous discussions with many employers as they have weighed these options. And I'd like to point out a few key things or points to consider as an employer when evaluating this area. Employers and employees currently receive a tax savings for current coverage in place with pre-tax deductions. If an employer opts to stop offering coverage and adjusts an employee's salary for them to find their own coverage, the employee loses the pre-tax deductions from their benefits and then is taxed at a higher income level. Any plan purchased on their own would be a post-tax deduction. Individual FSA plans were available in the past for employees to receive the tax savings, but that option was eliminated as of January 1st, 2014. Finally, benefits are part of an employee's total compensation package. They are a valuable part of recruiting and retaining quality staff. The employers I work with value this key piece and plan on continuing to offer coverage going forward with our help strategically, just as the poll showed.
Thanks, Courtney, so much. I appreciate that. Let's take a quick look at the various exchanges that individuals can take part in. All right. One of the most common terms coming out of the Affordable Care Act is exchanges, or health insurance marketplaces. So let's review what we are talking about when we speak of exchanges. The ACA created public and private health insurance exchanges or marketplaces available on the internet to facilitate the purchase of affordable and qualified health insurance coverage for individuals and small groups. When reviewing these exchanges online, you can compare plans, determine eligibility for tax subsidies, and elect coverage. All public exchanges will share similar characteristics. For example, plan offerings will be named Platinum, Gold, Silver, Bronze. There are 3 exchanges that we are going to speak to. The Small Employer Health Options Program, also known as SHOP, is an exchange through which small employers can offer coverage under qualified health plans for their employees and dependents scheduled for January 1st, 2015. In 2017, or planned for 2017, employers with 50 to 100 employees will have an incentive to participate in a SHOP. States that do not offer SHOP exchanges will be provided health care options through Health and Human Services, HHS. And this is a federally facilitated exchange. Originally, the HHS rule was that employers could choose the level of coverage, but employees were able to choose the carrier through the exchange. As of March 2013, HHS stated that both coverage and carrier will be an employer choice to offer, as is customarily done now. Private health insurance exchanges, if they're available in your state, are another option. In private exchanges, the employer selects a menu of plan options from one or more insurance carriers and decides on a dollar amount they will contribute toward employee health benefits. Employees then use the funds, plus any additional money that they want to contribute, to buy a plan of their choice. Some private exchanges offer as many as 20 coverage options. Private exchanges offer employees more choices than the shops and may also offer one-stop shopping for additional benefits, such as vision, dental, life, and disability insurance, which are not available in the public exchanges. With all of this, qualified health plans are being offered to individuals and groups. These qualified health plans meet the essential health benefits defined by the Affordable Care Act. There are 10 different coverage areas that make up the essential health benefits criteria. They are ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventative and wellness services, and chronic disease management, pediatric services, including oral and vision care. So you may be wondering at this point, what is the financial impact on me, the business owner or executive? Let's go on to review that now. First, some relatively good news. If you are an employer with fewer than 25 full-time equivalent employees, pay average annual wages of less than $50,000 per full-time equivalent employee, and pay at least half of the employee health insurance premiums, which is based on single coverage, you may be eligible for a tax credit. Please note that the tax credit can only be obtained if a company's insurance is purchased through a shop exchange, and this credit will only be available for 2 years. All right, so moving on to fees and penalties. Some employers are weighing the total cost of penalties versus the cost of meeting the ACA requirements, which again is referred to as play or pay. This slide is aimed at the specific question that you may be asking yourself right now. So let's start by reviewing the penalties that may impact you, the employer. The first scenario is when employers do not offer coverage to their employees, or the coverage that they do offer does not meet the plan or contribution requirements set by the ACA mandates. This penalty is $2,000 per employee and is based on the number of full-time employees for that month. To calculate the monthly penalty, you would take the number of full-time employees for that month, multiply by 1/12 of the penalty. When calculating this penalty, it is important to know that the first 30 employees are exempt from the penalty. The second scenario is when an employer offers coverage to at least 95% of its full-time employees, but at least one member receives a premium tax credit through the exchange. The penalty for this situation is $3,000 annually and assessed on a monthly basis. The maximum penalty is capped at $2,000 per employee minus the first 30 employees. Working backwards a little, the next item for review is the patient-centered outcomes research fee. This fee will cost employers $2 per member per year, starting for plan years ending after October 2012. Like we mentioned previously, this fee may rise with inflation, but it is scheduled to end in 2019. The fee is to be used for comparative effectiveness research, which is research that covers the direct comparison of existing healthcare interventions to determine which work best with which patients and which pose the greatest harm. Insurer tax. The next fee is insurer tax. This is approximately 3.5% of the premium to assist in the funding of health exchanges. Lastly, the transitional reinsurance fee is scheduled to be effective for 3 years, 2014 through 2016, as exchanges develop and mature. The 2014 fee is estimated to be $5.25 per member per month, or $63 per member per year. In an effort to be very clear about this fee, every single member on the plan will be considered for this fee, including dependents. This fee was established to help stabilize premiums and fund the reinsurance program. So what is next? To prepare for 2015, we recommend that employers analyze their workforce and health plans now. Some items to consider. Is your company a small or large employer? Or is the employer part of a controlled group with other companies? A company with less than 50 full-time equivalent employees, but part of a controlled group, may be considered a large employer. Consider how you are currently managing your part-time workforce. Keep in mind that the ACA mandates that any and all employees working full-time, which is over 30 hours, will be eligible for company-provided medical benefits. You will certainly want to manage the employee's work time more closely if you are not interested in offering coverage to these part-time workers. A few words of caution. Restructuring the workforce may help avoid having to provide insurance or penalties, but could negatively impact customer service, employee morale, the company's ability to attract new employees, and other important business considerations. Policies and procedures. Make sure that you have policies and procedures in place to track the number of full-time and part-time employees, as well as the number of hours worked by each employee. Organizations will be required to track employees and hours worked on a monthly basis to determine large or small employer status and potential liability for penalties. Please remember, if you are part of Tandem HR, we will be by your side during the entire process. All right, so let's run down a quick recap of some key dates for you to remember. These items are all scheduled to happen, but as you may have guessed, things may change. So on January 1st, 2014, as we know, the exchanges went active. Coming up on January 1st, 2015, the employer mandate for applicable large employers began. Also on January 1st, 2015, employers are required to track IRS-required information for all of their employees. Then the following year, on January 31st, 2016, the employer mandate to report to the IRS on employee coverage provided. January 1st, 2017, employers with more than 100 full-time equivalents will be able to purchase health coverage through the exchange system. January 1st, 2018, an excise tax on Cadillac health plans began. Cadillac health plans are those high-cost health plans when the aggregate value of the employer-sponsored health insurance coverage exceeds a specified threshold. Very good. So I'm actually, at this point, I'm going to turn it over to Courtney, who has been monitoring the questions asked during today's webinar. We're going to put her on the spot a little bit. She will select a few of those questions asked, and we, meaning Courtney will be providing the answer to those questions for the benefit of all of us present this morning. So thank you, Courtney.
Thank you, Rebecca. Okay, so a few key questions that have come up. Will I be able to keep my current group plan designs going forward? Most plans will have some adjustments made to comply with ACA changes at your next renewal. The amount of adjustments to the plan designs will depend on your medical carrier, and the size of your eligible employees. Small groups under 50 will see more changes than larger groups due to community rating and some of the additional things that Rebecca previously spoke about. Okay, another question. How is affordable coverage determined and when does that go into effect? The employee contribution cannot exceed 9.5% of employees' gross income for the lowest rated plan offered. The regulation will go into effect for groups that are 100 plus January 1st, 2015, and now with the delay for groups 51 to 99, it won't go into effect until January 1st, 2016. Final question, who is eligible for a subsidy if my employee chooses to look at the coverage with the exchange? So employees between 100% and 400% of the federal poverty level are eligible for a subsidy. They cannot be eligible for coverage through a government program such as Medicaid or CHIP. Can't be eligible for an employer plan, or employer coverage is unaffordable and does not provide minimum value coverage. Subsidies are only available through the government exchanges, which the state of Illinois is a state and federal-based shared program. All right, I think any other questions that we have, we will be responding within 48 hours, and I'll turn it back over to Rebecca.
Yeah, thanks, Courtney. So we're looking at 8:56 right now, so with respect for your time, we will be answering all remaining questions asked today with a personal email to you within the next 48 hours. If you have any further questions, please type them into the question box on the right of your screen, or feel free to contact me directly. My information is on the screen presently. We really hope that you enjoyed our presentation, that you found it simple, and you gained a better understanding of your options under the Affordable Care Act. Thank you so much for your time today that you spent with us. I hope that each of you have a wonderful day and weekend.